Hello learners, let us discuss the intersectionality of caste and religion in healthcare services. In healthcare, intersectionality helps to understand that social identities do not operate in isolation. For instance, a Dalit woman's experience in a hospital is shaped not just by gender or caste individually, but by the unique combination of both, often resulting in compounded barriers to care, increased stigma, and distinct health vulnerabilities. Intersectional analysis is crucial for redesigning policies and interventions that respond to the real-life complexity of discrimination and needs. Caste is a socially stratified hierarchical system most commonly associated with the Indian subcontinent, though similar system of inherited status exists elsewhere. In India, the caste system divides people primarily into four broad categories known as Varnas: Brahmins, Kshatriya, Vaishya, and Shudras, with Dalits, formerly known as untouchables, and Adivasis, like indigenous people, remaining outside these formal ranks. Caste status is ascribed at birth, hereditarily and relatively fixed, and determines social standing, occupation, and access to resources like education and healthcare. In healthcare, caste discrimination can mean denial of treatment, verbal or physical abuse, segregation in health facilities, and poorer health indicators for marginalized caste, particularly Dalits and Adivasis. Castes remain a powerful, though often invisible, determinant of health inequalities. Religion refers to organized systems of belief, practices, and ritual related to questions of existence, ethics, and the supernatural. In India and much of the world, religion is a core axis of identity, shaping cultural practices, dietary habits, understandings of health and illness, gender norms, and social belonging. Religious minorities such as Muslims, Christians, Sikhs, Buddhists, or Jains in India can face disadvantages and exclusion based on their faith, both in general society and within healthcare institutions. In health, religious beliefs influence everything from seeking or refusing specific treatments, for example, blood transfusions and reproductive care, to the accessibility and cultural appropriateness of facilities. In multi-religious societies, systemic or provider bias can further limit access to fair, respectful, and non-discriminatory treatment for religious minorities. Intersectionality arose as a critique of social analysis that treated excess of identities such as gender, race, and caste or class as independent and isolated, thereby overlooking how multiple forms of discrimination can work together to deepen disadvantages. Health interventions in India often focused on women or the poor as homogeneous groups, failing to recognize that Dalit women's experience of childbirth or a Muslim woman's experience of mental health care could be profoundly different from their upper caste or Hindu counterparts, owing to distinct forms of social exclusion and discrimination. Globally, health disparities by race, ethnicity, or immigrant status were long attributed to cultural or biological differences rather than seen as the outcome of intersecting social and institutional oppression. Intersectionality is crucial in contemporary healthcare for several reasons. First, diagnosis and data. It prompts researchers and practitioners to disaggregate health data by multiple identities, example gender and caste, or race and sexuality, revealing disparities otherwise hidden in population averages. Second, policy and practice. Intersectionality empowers the creation of nuanced policies and programs that better target the actual biases faced by various communities, such as language access for religious minorities or disability accessible clinics for women with disabilities. Third, patient experience. It highlights why equal treatment is not always equitable, as different groups need different support to achieve similar health outcomes. Recognizing intersectional risk factors helps providers avoid stereotypes and deliver truly responsive care. And fourth, Advocacy and reform. Intersectionality provides the essential lens to move beyond single axis explanations for health disparities, revealing how overlapping identities create unique and often lethal barriers to care. In the Indian context, this framework explains why Dalit women face significantly higher rates of maternal mortality compared to dominant caste women. This is not merely a product of poverty or gender bias in isolation, rather is the result of the compounded effort of caste, gender, rural location and religious identity. For a Dalit woman in a remote village, the struggle is not just about the distance to a clinic, but also about the potential for touch avoidance by provider, the lack of familial financial autonomy, and a historical legacy of structural violence that has systematically underfunded health infrastructure in marginalized settlements. Data from the National Family Health Survey 5 underscores these disparities with concrete numbers. For instance, the maternal mortality ratio for Dalit women has historically been estimated to be significantly higher than the national average. While the national MMR has improved to roughly 103 per 100,000 live births, studies indicate that for the scheduled castes or Dalit and the scheduled tribe like Adivasi women, these figures can remain drastically elevated in specific high burden states. Furthermore, only about 60% of the Dalit women receive full antenatal care compared to nearly 75% of women from general categories, illustrating a clear representation gap in service utilization. Let us understand the evolution of intersectionality in India. India has historically been defined by complex and deeply interwoven social stratifications, primarily caste, religion, gender, class, tribe, and region. For centuries, these overlapping structures have functioned as the primary gatekeepers to resources, education, and healthcare. However, both colonial and early post-independence health policies frequently relied on a siloed approach to these identities. By categorizing the population into broad, distinct groups such as backward castes, minorities, or women, the state treated these populations as homogeneous blocks. As noted by Sen and Iyer 2012, this reductive strategy failed to account for the unique situational barriers that arise when these categories overlap, such as the specific healthcare challenges faced by a poor, rural, Dalit women compared to an urban middle-class woman from a similar caste background. The 1970s and 1980s marked a pivotal epistemic break in Indian social movement as the singular narratives of the mainstream feminist movement and the male-dominated anti-caste movement were forced to confront their internal exclusions. During this era, Dalit feminist scholars and activists began explicitly highlighting that women's issues and caste issues were not parallel tracks but were deeply intertwined in the lives of marginalized women. This intellectual and grassroots insurgency challenged the dominant upper caste urban narrative of Indian feminism, which has largely focused on middle class concerns like the glass ceiling, while ignoring the structural violence of untouchability and manual labor faced by Dalit women. The realization birthed the Dalit feminist standpoint, which argues that the most marginalized women possesses the most comprehensive view of how power operates in society. By 2026, this framework remains essential for achieving clinical justice as it reveals that a healthcare system designed by and for the elite will naturally fail to see the specific vulnerabilities such as nutritional neglect or touch avoidance discrimination that define the Dalit women's experience. During the 1990s and 2000s, a transformative shift occurred in India gender and health studies as scholars began to integrate Black feminist theory and global intersectionality concepts into the local context. Moving beyond a singular focus on women as a monolithic category, researchers such as Geeta Sen and Asha George pioneered a more granular analysis of the Indian healthcare landscape. Their work, notably summarized in Sen, Austin, and George 2007, demonstrated that a woman's health is not merely a product of her biology or general patriarchal culture, but is instead shaped by a specific compounding pressure of gender, caste, class, and religion. These intersecting identities act as a gatekeeper system, determining who can enter a clinic, who receives dignity from a provider, and who's most vulnerable to systemic neglect or physical violence. Large scale reports and data collectives, for example, NFHS, Such a Committee report, Indian Exclusion Report, revealed persistent health gaps even where formal education policies existed. These disparities were clearest at the intersection of marginalized caste, gender, religion, region, and degree of urbanization. Maternal health programs began to show that Dalit and Adivasi women had much worse mortality rates due to both caste-based discrimination by health workers and gender-based restrictions on mobility and decision making. HIV or AIDS advocacy emphasizes intersectional risk, for example, for sex workers facing stigma due to caste, class, and gender or trans identities. Public health activism during the COVID-19 pandemic again spotlighted how Dalit or tribal status, religious identity, example, anti-Muslim stigma, migration status, and gender shape different vulnerabilities and access to services in India. Today, intersectionality in India is increasingly recognized in many areas, like academic research design, calling for disaggregation of data not just by gender but also by caste, religion, region, etc. Second, in NGO programming, targeting Dalit, Adivasi, and minority women's health needs in culturally sensitive ways. Third, judicial advocacy, legal practitioners around sterilization abuse, reproductive right, and violence acknowledge intersectional injustice. And fourth, health systems policy that calls for more inclusive training, diverse health workers, recruitment, and anti discrimination protocols. However, challenges remain. Intersectionality is still more present in academic or activist circles than in mainstream policy or daily clinical practices. Routine health data often fails to capture or address these layered realities, and most providers lack detailed intersectional training. Access to healthcare services for Dalit and Adivasi women is frequently obstructed by deeply embedded system of segregation and exclusion. In many rural and peri-urban contexts, these women are systematically denied entry to certain health facilities or are forced to wait significantly longer than dominant caste patients for basic consultations. Research by Scott and Shankar 2010 highlights a disturbing pattern where marginalized caste patients are often neglected to separate substandard spaces or resources within clinics, reflecting a special manifestation of untouchability that persists in the modern medical landscape. This institutional invisibility ensures that their specific health needs remain unmet as they are forced to navigate a system that fundamentally views them as other. Castes serve as a deeply entrenched social hierarchy in India and parts of South Asia, functioning as a rigid system of stratification that dictates an individual's social status, traditional occupation, and economic opportunities from the moment of birth. This identity is ascribed meaning, it is inherited rather than earned, and it remains inextricably linked to historical pattern of discrimination, segregation, and structural disadvantages. For those at the bottom of this hierarchy, caste is not just a social category, but a determinant of one's access to fundamental rights and life-sustaining resources. The most marginalized groups, specifically Dalits and Adivasis, face a reality defined by systemic exclusion. As noted by Deshpande 2011, this exclusion permeates every facet of public life, including education, employment, and the justice system. Caste remains a deeply entrenched social hierarchy in India and across several South Asian societies, functioning as a rigid system that dictates an individual's social status, traditional occupation, and economic mobility from the moment of birth. Unlike class, which can be fluid, caste identity is ascribed an immutable, inextricably linked to historical patterns of systemic discrimination, spatial segregation, and unequal status to fundamental rights. As noted by Deshpande, this hierarchy creates a tired reality where the most marginalized group, specifically Dalits and Adivasis, face institutionalized exclusion that spans education, employment, and public life. The health outcomes for Dalit and Adivasi women in India represent a stark manifestation of structural violence where social hierarchy translates directly into physiological harm. According to data from the National Family Health Survey 5, these women experience significantly higher rate of maternal mortality, chronic anemia, and malnutrition compared to their upper caste counterparts. The disease burden among these communities is further exacerbated by a lack of environmental justice. Lower caste neighborhoods and tribal hamlets are frequently the last to receive adequate sanitation, safe drinking water, and consistent immunization services. This institutionalized neglect significantly increases the risk of infections, diseases, and waterborne illness, creating a cycle of poverty and ill health that is difficult to break. Furthermore, caste-based sexual violence remains a critical and life-threatening risk. In many regions, perpetrators of such violence enjoy high levels of impunity due to a legal and law enforcement system that often mirrors the country's social stratifications. This environment of threat not only causes direct physical and psychological trauma, but also acts as a profound barrier to health-seeking behavior, as survivors may fear further victimization or clinical gaslighting from the very institutions meant to provide care. In 2026, addressing the outcomes require a radical shift towards clinical justice, ensuring that the most marginalized are no longer invisible within India's public health data or its justice systems. Dalit and Adivasi women are also underrepresented in higher level healthcare roles and overrepresented in the most precarious health jobs, such as accredited social health activists known as Ashas and Anganwadi workers, where they face low pay, lack of recognition, and job insecurity. Let us discuss some barriers to healthcare for marginalized caste women like Dalits, Adivasis, and OBCs. Social discrimination and stigma remain some of the most pervasive barriers to healthcare for marginalized caste women in India, manifesting as both explicit and subtle form of caste-based exclusion. Within health facilities, Dalit and Adivasi women frequently report being made to wait significantly longer than dominant caste patients, often being bypassed by those who arrive later but possess higher social capital. This critical waiting tax is compounded by disrespectful communication from providers and administrative staff who may be derogatory language or dismissive tones, effectively silencing the patient's concerns. Economic status serves as a powerful gatekeeper to health sovereignty, particularly for Dalit, Adivasi, and many other backward class women who are disproportionately represented among India's working poor. Because these marginalized caste identities often overlap within landlessness and informal labor, the sheer cost of medical engagement, ranging from specialized medicines to the high fee of private clinics, remains prohibitive. Even when free public health services are available, the hidden cost of transportation to distant districts, hospitals can equal several days' worth of household wages. This creates a caregiver tax where the financial risk of seeking care is weighed against the immediate need for food and shelter, often leading to a dangerous delay in diagnosis for chronic or acute conditions. Furthermore, the absence of financial autonomy within the patriarchal structure of many marginalized households means that women often lack the independent means to prioritize their own well-being. By 2026, addressing these economic barriers requires moving beyond simple subsidies True clinical justice necessitates the implementation of universal health coverage that accounts for the last mile cost of travel and the loss of daily wages. According to principle of structural violence theory, until the economic foundations of caste and gender inequalities are addressed, the healthcare system will continue to reproduce the very disparity it aims to heal. For Adivasi women living in the remote tribal regions, geographical isolation and decaying infrastructure serves as physical manifestation of structural violence. The historical and systemic neglect of these areas means that essential healthcare facilities are often located several dozen kilometers away, requiring patients to navigate arduous terrain just to reach a primary health center. As noted by Scott and Shankar 2010, this lack of nearby facility transforms a routine medical need into a logistically complex and dangerous expedition. For a woman in labor or a patient in a respiratory distress, these long distances are not merely an inconvenience, they are a direct threat to survival, often resulting in preventive fatalities before a hospital is even reached. Limited health awareness and information represents a significant barrier for marginalized caste and tribal women, often stemming from historically lower literacy rates and systemic exclusion from mainstream public health messaging. When health communication is designed for a universal, typically urban, upper caste, and literate audience, it fails to reach those at the intersection of multiple disadvantages. This lack of tailored information means that many Dalit and Adivasi women remain unaware of their reproductive rights, specific disease prevention strategies, or their legal entitlements under various government welfare schemes. Provider bias and systemic neglect serve as primary drivers of clinical injustice, as healthcare providers, often from dominant caste backgrounds, frequently carry internalized prejudices into the exam room. This caste bias manifests in the chronic undertreatment or dismissal of complaints where the pain and symptoms of Dalit and Adivasi women are minimized through a "you'll get by" attitude. Such clinical gaslighting is not merely a failure of empathy but a structural mechanism that denies marginalized patients the same diagnostic rigor afforded to upper caste individuals. Next is cultural insensitivity and lack of trust. Cultural insensitivity and a fundamental lack of trust represent profound psychological barriers to health sovereignty, often serving as the final deterrent for marginalized women. When the allopathic medical system operates through a Eurocentric or dominant caste lens, it frequently treats traditional healing beliefs and indigenous knowledge with open derision. This dismissal of standpoint theory, the idea that marginalized communities have valid, lived insights into their own well-being, creates a confrontational dynamic rather than a therapeutic one. The mobility restrictions and entrenched gender norms function as a fundamental barrier to health sovereignty, dictated by patriarchal traditions that often confine women to the domestic sphere. In many communities, a woman's physical presence in mixed gender public spaces, including health clinics or hospitals, is strictly regulated by male relatives or community elders. When a woman cannot leave her home without a male escort or explicit permission, her access to time-sensitive medical care, such as emergency contraception or prenatal screening, is effectively served. The fear of violence and reprisal constitutes a profound psychological and physical barrier, transforming the simple act of seeking medical care into a calculated risk for Dalit and Adivasi women. In a society where caste-based sexual violence is frequently used as a tool of systemic subjugation, these women must navigate a landscape of constant threat. This environment of slow violence means that the journey to a clinic, often through isolated roads or dominant caste territories, expose them to potential assault. Tragically, this risk is not confined to the journey. It occasionally extends into the very healthcare facility meant to be centuries of healing. This creates a deep-seated trust deficit, where the medical establishment is viewed not as the source of clinical justice, but as an extension of the patriarchal and casteist structures that operate outside its walk. When a woman fears that seeking a maternal checkup or treating for the chronic illness could lead to reprisal or violation, she is forced into a state of medical neglect to ensure her own security. Administrative barriers function as a paper ceiling that reinforces structural violence, effectively disenfranchising Dalit and Adivasi women from the very welfare systems designed to protect them. Access to transformative schemes like Janani Suraksha Yojana for maternal health or Ayushman Bharat for universal health insurance is strictly predicated on the possession of specific government identity, social security, or caste certificate. However, due to historical displacement, lack of land titles, and the palocentric administrative bias that often ignores women's independent identity, marginalized women are significantly less likely to possess these required documents. The process of obtaining these documents is often fraught with further caste-based discrimination and bureaucratic gatekeeping. Marginalized women may face clinical gaslighting and administrative offices where they are spoken to disrespectfully or their applications are deprioritized by dominant caste officials. This lack of health sovereignty means that even when a woman reaches a hospital, she may be turned away or charged exorbitant fees because her eligibility cannot be verified on a digital portal. Let us understand the connection between religion and health, which means the access and exclusion for women of different religion. Religious identities serve as a profound social determinant of health, shaping not only an individual's sense of belonging and community support, but also their fundamental health benefits and practices. In the context of India and Global South, religion is not merely a private matter of faith, it is a structural force that dictates social status and, by extension, the quality of interaction one has with the state's medical apparatus. For women, this intersection is particularly acute as they often navigate a double burden or gendered expectations and religious forms. These norms can influence everything from reproductive choices and dietary habits to the level of financial autonomy they are granted to seek professional care. The barriers to access for minority women include social and institutional discrimination. Social and institutional discrimination against religious minority women, including Muslim, Christian, Sikh, and Buddhist women in India, act as a significant barrier to clinical justice. These prejudices often manifest as a direct result of stereotyping and bias, where visible markers of faith such as hijab, a cross, or specific cultural attire trigger differential treatment by healthcare staff. Reports indicate that these women frequently face overjudgment or neglectful care, as providers may project communal or social biases onto their patients. Furthermore, provider bias, whether conscious or unconscious, deeply erodes the patient-provider relationship, leading to a profound trust deficit. Healthcare workers harboring these biases may offer less attentive care, skip essential diagnostic steps, or show a marked reluctance to provider-sensitive services, particularly regarding reproductive health and family planning. Economic inequality and religious marginalization are deeply intertwined, creating a reinforcing cycle of vulnerability that restricts health sovereignty. In India, data from Periodic Labour Force Survey 2022-23 and various Niti Aayog reports indicate that religious minorities, particularly Muslims and certain Christian tribal groups, are disproportionately represented among the urban and rural poor. For instance, the Sachar Samiti report historically highlighted that the socio-economic status of Muslims was often lower than that of scheduled caste and tribes, in several indicators. By 2026, while some gaps have shifted, the wealth gap remains a primary barrier to accessing quality healthcare. Poverty acts as a physical and systemic wall. For women in these communities, the formal medical system is effectively inaccessible. Next are the administrative barriers. Administrative barriers act as a paper partition that codifies structural violence, specifically targeting communities with histories of displacement, communal stigma, or recent religious conversation. For groups such as converted Christians, refugees, or Muslim populations facing local prejudices, the simple act of providing one's identity to the state becomes a gauntlet of exclusion. These communities are disproportionately likely to lack the correct documentation, such as legacy data, caste certificates for those who have converted, or updated residential proof required to access life-saving entitlements like maternal health benefits or state-sponsored insurance. The lack of awareness about entitlement is not a personal failure of these women, but a result of information, poverty, and international exclusion from mainstream outreach. First, modesty and restrictions on mobility. Expectations of modesty profoundly influence a woman's willingness to seek care, particularly for reproductive or sexual health. In many conservative traditions, the prospect of being examined by a male provider is a significant deterrent, leading to delayed or foregone care. This is compounded by mobility restrictions where women may require a male chaperone to visit a clinic. Second, health beliefs and practices. Health beliefs and practices are not static. They are deeply embedded in a community's moral and social fabric. When religious doctrines or the fear of communal stigma intersect with modern medicine, they create a complex landscape of negotiated health. For many women, standpoint theory suggests that their medical choices are governed by a rational need to maintain social belonging and spiritual integrity. In 2026, failing to address these nuanced results in clinical injustice, where a woman is forced to choose between her faith-based community and her physical health. Theological interpretations regarding the beginning of life or the sanctity of the womb often shape a woman's engagement with contraception and abortion. Catholic and Muslim women, for instance, may avoid legal reproductive services not just due to personal belief, but due to the pervasive fear of social ostracization. The pursuit of ritual purity often leads to profound secrecy regarding STIs. The pursuit of ritual purity often leads to profound secrecy regarding STIs, HIV or AIDS, or mental health struggles. In many faith traditions, these conditions are erroneously viewed as moral failing or divine punishment. This stigma prevents women from seeking early diagnosis, as the shame of the condition is seen as a threat to family honor. The resulting medical neglect is a form of structural violence, where the silence of community becomes a barrier as physical as a locked clinic door. Preventive measures like vaccinations or organ donation can sometimes be viewed through a lens of religious suspicion, often fueled by historical mistreatment or contemporary misinformation. When a vaccine is rumored to interfere with fertility or contain non-permissible ingredients, hesitancy becomes a communal survival strategy. According to the principle of cultural humility, the medical establishment must stop labeling these concerns as irritational and instead engage with religious leaders to co-create messaging that is both scientifically accurate and theologically respectful. Ritual practice and dietary laws are significantly cultural drivers of health outcomes, particularly in the management of chronic conditions like anemia and the efficacy of nutritional interventions. In many Indian and global South contexts, religious life is governed by a cycle of fasting and specific dietary restrictions that, while spiritually fulfilling, can conflict with standard allopathic treatment protocols. The nutritional impact of fasting and dietary laws create a complex psychological challenges for women, particularly when religious cycles intersect with critical health windows like pregnancy. Fasting cycles, including observance such as Ramadan, Navratri, or Lent, necessitate dramatic shift in calories and fluid intake that can be physically taxing. For pregnant women or those managing pre-existing conditions such as gestational diabetes or severe anemia, the practice of extended fasting may lead to maternal exhaustion and serious fetal growth concerns. When the body is deprived of consistent glucose and hydration during these sacred periods, the risk of hypoglycemia and low birth weight increases, illustrating a tension between spiritual devotion and clinical safety. Furthermore, dietary restrictions ranging from the prohibition of specific animal protein to traditional beliefs regarding heating or cooling foods can severely limit a woman's intake of bioavailable iron and essential micronutrients. Beliefs regarding ritual purity often dictate how and when a woman can access specific treatments. In some traditions, menstruation is viewed as a period of impurity, which may prevent women from visiting certain health facilities or participating in community-based health screening. This can lead to delays in diagnosis, reproductive tract infections, or managing menstrual hygiene. The acceptance of medical supplements such as iron, folic acid tablets, or vaccines is often contingent on their perceived purity. If a supplement is rumored to contain non-permissible like non-halal or non-vegetarian stabilizers or coatings, a woman may refuse treatment to avoid spiritual transgression.
Thank you.